Diversity and inclusion is such an important conversation that's happening in each of our communities and across every sector, including healthcare. One strategy to increase diversity and inclusion initiatives is through implicit bias training. And I know both of us have had some implicit bias training. So Janice, as a medical student, I was wondering if you could tell us a little bit more about your training through medical school.
Yeah, I'd love to. So our medical system was really designed to base medical diagnoses off of white male physiology. We were taught that a heart attack looked like an elephant sitting on your chest, pain radiating down your left arm, and that was it. And research found that doctors were missing signs of heart attacks 50% of the time when they happened in women.
Wow.
That's because in women, they look different. They look like pressure and fullness of the chest, what they were calling anxiety attacks or acid reflux disease. And so when it comes to the conversation of implicit bias training, it's not something that can be done in a lecture because this is really inherent. It has come at the expense of minorities and women. At Ohio State, our implicit bias training is really embedded in our curriculum. We get tested on it, we have simulations on it, and there's so many safeguards or reporting systems in place to make sure that we're not putting patients in harm's way.
Absolutely. So you mentioned some of these safeguards. Is it fair to say that these safeguards are protecting against the implicit bias?
Well, no, that's not what I'm saying. I've seen bias, but perhaps not in the way you're thinking.
Okay. Well, tell us more.
So the conversation about bias isn't just that it's bad. Bias is bad because it can cause unintended harm. And we've talked a lot and we've had a lot of research about how providers are in a position to cause patients harm, but there's not so much a conversation about how patients can cause a provider harm. And I'll just share a brief story to illustrate this. I was working in the hospital and going to a patient's room with my attending, who's kind of like an older doctor. And we went into the room and the patient was visibly upset. He pointed to my attending and said, "I don't want any Jews taking care of me." Pointed to me and said, "I don't want any black people taking care of me." Except he didn't say, "I don't want any black people," right? He called me the N-word, which was the first time I'd ever been called that in my entire life. And then he threw a pillow at us. So it was a very tense atmosphere. And my attending tried to kind of diffuse that situation, and we left the room. And as we were walking down the hall, I think to make light of what was a really heavy situation, my attending turned to me and he goes, "I'm not even Jewish." And I remember walking down the hall and I was like, well, I'm still black.
It sounds like this was a very pivotal moment. Can you share how you processed this?
Yeah, it was tough after that because there was a little bit of fear that it stayed with me after this happened. And I remember later I was processing this with my mentor, and I realized that because of what happened in that room, I'd been acting under the influence of bias. There was a later patient that I guess reminded me of that first guy, and I was in the room with him rushing through his physical exam. Whoops. I was asking him questions, not really digging deeper as a good medical student should. I just wanted to get out of the room. And patients have come to expect at least 15 minutes with their doctor, which isn't enough. But in the situation where I was uncomfortable, I was anxious, I was a little afraid, I couldn't even give the patient that. And the question is, what does it mean for that guy's care if I couldn't even give him the 15 minutes he'd come to expect? And what I'm trying to say is that even with all of these training and systems in place, bias can still sneak up on you.
Absolutely. Can you talk to us a little bit about the mechanisms that are in place currently to help prevent this?
There's not any mechanisms to prevent this from happening. If a patient swung at me, no one's expecting me to stand there and take it. If my attending said any of this to me, no one's going to expect me to take it. But microaggressions or explicit aggressions from the patient, your feelings get hurt, and that's kind of where it ends. And it's unfortunate because medical systems and hospitals are spending so much money and so much effort into recruiting the most diverse talent. Every year, there's more women than men entering the medical schools. Ohio State graduates the most black doctors out of any school in the country, excluding the HBCUs. But you're putting us all into this system, this healthcare system that was built to exclude us. And you're putting us in front of patients who don't recognize us as part of the healthcare team. And that's kind of the tension that we're left with.
So as we think about all the research, the great research that's happening, the best practices that are starting to be developed, what recommendations would you have for us?
You know, it's a funny story. I know we were just briefly chatting backstage, but the American Medical Association has been writing a lot about this because we were able to make such headway into addressing implicit bias to the patient. And one of the strategies they've recognized is the concept of allyship, which is essentially you seeing something and saying, this isn't right, and I'm standing with the person who's been harmed. And I had an experience with it while I was on the stroke unit. My resident, Matt, who isn't here, but he and I went to a patient room and I was doing an exam and, you know, trying to listen to the patient's heart and, you know, do everything. And the patient was like hitting on me, making comments. It was like, you're so exotic, just like inappropriate comments, more gender than race. But definitely made me uncomfortable. But I remember standing there and I was just like, oh, it's a Wednesday. You know, you can't, it always seems like you can't be too sensitive or else I feel like no one else sees it anyways. There's no point in being sensitive about it. But when we stepped out of the room, Matt turned to me and he goes, well, that was gross. And I remember being stunned a little bit because I was like, wow, someone else saw that, you know? And then he said, you don't have to go back in there. And I was trying to be a good med student, so I was like, no, of course, I'll go back in there and see the patient. And he said, well, if you choose to go back in there, I'll go there with you. And that was all he said. But it meant a lot to me because it meant he saw what happened and that it wasn't right, and that he was willing to stand beside me. And he did go back in there when I later on went to check on the patient. And Matt's just a resident, meaning he just graduated medical school. He's not finished training. And that's kind of the future that's coming. So it made me happy to see that.
Great people like Matt and a great example of allyship. You'd also mentioned mentorship. Can you talk a little bit about mentorship and how that's important?
Well, actually, my mentor is a colleague of yours.
Really?
Yeah, Dr. Quinn Capers is my mentor. He runs implicit bias training for our health system, and he's a cardiologist. I was randomly assigned to him my first year, but it's been a great match. Because of his work on implicit bias, he's steeped into this research and really is intentional about how he's been training me. But also he's a Black man in medicine, so a lot of times I feel like I don't have to explain the history behind my anxieties. He kind of just gets it. And when we started working together, he said, okay, you're gonna learn how to be a doctor, like what to know in the classroom, but when you come with me, I'm gonna teach you kind of like the skills, like how to be a doctor, how to hold a patient's hand and tell them bad news. And we'd leave a patient's room and he'd be like, okay, what went wrong? What went best? You know, how can we fix it for next time? So I have a really safe space with him and allows me to kind of pick out the things that I'm just like, oh, I should have done better, ask him for advice. And that's how I was able to recognize that initial experience was changing the way I was practicing.
Absolutely.
And you know what, actually, the really powerful thing, I know he's a Black man in medicine, so it's like I can identify, but someone like Matt, who's a white man in medicine, because he was able to be such a strong ally, it puts him in a position where now he can identify what's wrong. And he can still serve as a mentor, you know, because of that ability to recognize the wrong. That's
great. So if we think about allyship, mentorship, if you had to pick one other thing, what would it be?
We'll think globally, I guess, you know, think systemically. If we look nationally, the American Nurses Association has been on the front line demanding a safer work environment because they are quite literally in physical harm's way with some patients. And I mean, the nurses union is something to be respected, you know. Medicine is still in this customer service mentality. If you don't want a Black doctor, you don't have to have a Black doctor is how it kind of goes. That's really unfortunate because you shouldn't be able to choose your doctor based on their race and ethnicity or gender, you know. That's not a reason to exclude someone from caring for you, and it doesn't breed a good working environment. So I think that as a system, we have to kind of put a no-nonsense, we're not tolerating it, you know. Perhaps there can be another reason to prefer another physician, but certainly not because of what I look like. There's a statistic that came out last year from the American Psychiatric Association. They said every single day, one doctor committed suicide.
Staggering.
Every single day. That's more than twice the general population. And it's a number that you don't really socialize around a lot, and there's so much that goes into that number too. But the question is, like, why aren't we doing everything in our power to get at it?
Oh, absolutely, absolutely. When we think back to just a couple years ago and where we are today, and thinking about the pipeline and how that pipeline has improved with underrepresented minorities and also gender balance in the medical school classes, it's quite inspiring how we've moved this far, and yet we have these areas that still need developed, so much so. And just want to say, absolutely thank you for your work in this area.
There's hope, people are coming up that have been trained differently and I think are ready to usher in kind of a change.
So proud of you. Wanted to say thank you for your time today.
Yeah, thank you.